shuffle their feet along the floor as they walk because they're unable or less able to raise their feet off the floor. So it's known as a magnetic gait because they walk as if their feet are stuck to the floor. And secondly, these patients typically develop urinary incontinence as well, presumably because the bladder control neurons are situated fairly close to a dilated lateral ventricle. And typically in these individuals, a peritoneal shunt that shunts the excess CSF that's being produced typically in one of the ventricles is curative. Finally, individuals that have severe neuronal loss, patients with Alzheimer's dementia that are losing brain tissue that results from neurologic diseases, atrophy, stroke, so on and so forth, will also have dilated ventricles that are readily evident in imaging, but again will have normal CSF pressure and not the signs of a patient with NPH. But typically, these individuals with wide varieties of neuronal conditions will have dilated ventricles, and this is known as hydrocephalus ex vacuo. The other point to be made is, looking back at this previous picture, is that individuals that have a communicating hydrocephalus may show up differentially on imaging. So, for example, it's important to recognize where a ventricle and why a series of ventricles will be dilated relative to an individual blockage site. For example, if there is a blockage at a foramen of Monroe, only one of the lateral ventricles will be enlarged. If there is a blockage at a level of the cerebral aqueduct, then the imaging will show both lateral ventricles being enlarged as well as the third ventricle, but the fourth ventricle being of normal size. And then finally, the other site where you can develop a non-communicating hydrocephalus might be at a blockage of one or more of the openings that allow exit from the CSF, and then in that case, all of the ventricles will be enlarged as a result. So an image basically can give you an instant clue as to where the cause, particularly of a non-communicating hydrocephalus, is based on which ventricles appear of normal size and which ventricles, one or more, are subject to enlargement. Then, typically, the concentration of CSF typically has a fairly low concentration of protein, and meaning that increased protein levels indicated or detected on a spinal tap might indicate the presence of a CNS tumor. Normal CSF has very few white blood cells, so again, if that number is elevated, that obviously can indicate a pathologic condition. Red blood cells are not normally found in cerebrospinal fluid, but certainly might be present in a bloody spinal tap or might be there as a result of a subarachnoid hemorrhage. Increased protein levels, as we indicated earlier, are a classic indication of a CNS tumor because protein levels are much lower in CSF compared with normal arterial blood. And again, tumor cells may also be present in the CSF in individuals that have a meningeal involvement because of the close association certainly of the meninges with the arachnoid space. Let's now deal with the anatomy and clinical neurology of arguably the simplest part of the central nervous system, and this is the spinal cord. But as we'll see, the spinal cord is going to be the location where we talk about three fundamental neural systems that have neural components found throughout the CNS that begin or end at spinal cord levels. First off, the fundamental anatomy of the spinal cord. It's housed in the vertebral canal. It begins at the caudal end of the brainstem near the foramen magnum with the medulla, and it ends basically in postnatal life at the level of the second lumbar vertebra. And we know well that there are 31 pairs of spinal nerves that arise segmentally from the cord, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and a single coccygeal pair of spinal nerves. And in terms of the spinal cord itself, as is the case for all of the central nervous system, there's a very precise histological organization. We're going to have areas of gray matter and areas of white matter in all parts of the CNS. In the spinal cord, the gray matter is centrally located and is shaped like a funny-looking H or a butterfly. And gray matter, not only in the spinal cord but everywhere else in the CNS, is where we're going to find all of the neuronal cell bodies of any neuron that's located in the spinal cord, along with their dendrites and the proximal parts of their axons. White matter in the spinal cord will surround the gray matter on all sides. White matter is going to be tremendously important because it contains bundles of functionally important specific axons that form a series of tracts of axons or fasciculi, and these axons fundamentally will either go up or down various parts of the spinal cord or ascend or descend its entire length. Let's now look at the fundamental anatomy of the spinal cord and the roots of a typical spinal nerve. The section that's shown on this particular diagram could be from anywhere in the spinal cord, and what you can see is the arrangement of gray matter forming the interior of the spinal cord in the form of a butterfly or an H, and you can see that the gray matter is surrounded entirely by white matter. Note that, again, the gray matter is going to be the location of any neuron cell bodies and dendrites of any spinal cord neuron, whereas the white matter is going to be the location of where we find bundles of axons in the form of a tract or a fasciculus. Note also that we have 31 pairs of spinal nerves as we illustrated previously, but also note that every branch of every spinal nerve is mixed in that it contains both motor and sensory fibers. And we know from gross anatomy that all spinal nerves branch into a mixed dorsal ramus and a mixed ventral ramus. But here's the additional point. Since all of the branches of a spinal nerve are mixed, every spinal nerve must have a sensory root and every spinal nerve must have a motor root. The sensory root of a spinal nerve is the dorsal root. Its central process of its axons enter at the dorsolateral point of the spinal cord. And since all dorsal roots are derived from neural crest cells, their cell bodies are logically found in a ganglion outside the CNS, in this case in the dorsal root ganglion. The cell bodies of all ventral roots are derived from the neural tube. Therefore, their neuronal cell bodies are found inside a specific part of the gray matter of the spinal cord, and it is only their axons that are coursing in a ventral root on their way to branching and forming part of a dorsal or a ventral ramus. So let's look in a little more detail at the organization of the gray matter, because in addition to forming the locations of neurons, of any neuron in the spinal cord, it has some functional specificity in that the dorsal horn of the gray matter contains sensory neurons, or neurons that are going to respond to sensory input provided to them by the incoming dorsal root. The ventral horn is going to contain motor neurons, in this case, the motor neurons whose axons leave in the ventral root. The intermediate zone, which is part way between the dorsal horn and the ventral horn, is a combination of motor and sensory neurons and includes preganglionic autonomic neurons in spinal cord segments from T1 to L2 and S234, and also contains some sensory neurons in what is known as Clark's nucleus, which is also found from T1 to L2. So the intermediate zone we cannot call either motor or sensory because its neurons have functional specificity for either the autonomic nervous system or some cerebellar type sensation. The next slide summarizes in chart form the basic anatomy of the spinal cord. Note the difference in the corresponding terms. The conus medullaris is the tapered distal end of the spinal cord that contains sacral and the coccygeal spinal cord segments, and in adults ends about the level of the L2 vertebra. The cauda equina represents the dorsal and the ventral roots of lumbosacral and coccygeal spinal nerves that descend below the conus medullaris on their way to exit out of their proper intervertebral foramen. The filum terminale is technically a component of the cauda equina. It is a peel extension that extends below the cauda equina that tethers the spinal cord basically to about the level of the S2 vertebra at the bottom of the vertebral column. And again, dorsal root ganglia contain the cell bodies of primary sensory neurons. Of all primary sensory neurons, they're neural crest cell derivatives. All spinal nerves are going to have a dorsal and a ventral root, making up obviously a pair of roots that join together to form a spinal nerve. As we indicated, we were more specific about it previously. The dorsal horn contained neurons that respond to sensation. The ventral horn contains motor neurons. And the intermediate zone, although not listed here, is a combination of autonomic and sensory neurons between the two horns. And then we're going to use these criteria to help us identify where we are in a particular spinal cord segment. Note that the area of the cervical enlargement and the lumbar enlargement are areas where we're going to find many more motor neurons, particularly, and a larger number of sensory neurons, because these regions of the spinal cord are the segments that provide the innervation to an upper limb or an innervation to a lower limb. So there are going to be some anatomic differences in these regions of the spinal cord, which will help us localize where we are. The cervical enlargement corresponds to the origins of the brachial plexus, and that is the C5 through T1 spinal cord segments, where the lumbar enlargement corresponds to lumbosacral spinal nerve segments from L2 to S3 that's providing a corresponding innervation to the lower limb. And then kind of a 3D kind of picture illustrates again the arrangement and anatomy of the spinal cord. You could see again the features of the gray matter and how it's divided into dorsal or posterior gray horn, anterior or ventral corresponding horns for motor, the intermediate or lateral horn, the home of autonomic neurons and some sensory neurons, and you could see how the rootlets come out of each corresponding segment, ventral and dorsal, combined to form a spinal nerve that then ultimately branches into its corresponding rami. All right, so now let's get specific by looking first at the anatomic differences between the functionality of various kinds of dorsal roots versus the various kinds of ventral roots, because they obviously have very different functions, and in addition, they have different sites of termination and different degrees of myelination. What we're seeing here is the anatomic differences in the dorsal roots. Note that all of their cell bodies are certainly in dorsal root ganglia because they're neural crests, but note there's a very distinct differences in their sites of termination in the spinal cord and their functionality. Note that we subdivide a dorsal root into a medial and a lateral division. The medial division of the dorsal root contained the heavily myelinated, fastest conducting dorsal root fibers. And these have a classification scheme basically that's either based on Roman numerals if they're innervating muscle, or an alphabetic scheme if they're innervating receptors in skin. So note that the largest, most heavily myelinated dorsal root fibers are those that mediate the sensation of proprioception, muscle position sense. And there are two classes of these. 1A fibers are innervating what we call muscle spindles. Those are muscle stretch receptors. 1B fibers are going to innervate Golgi tendon organs. Both are different kinds of receptors that are basically incorporated into skeletal muscle. In addition, the other component modality fiber that is in a dorsal root are the fibers that mediate the corresponding touch modalities of pressure sense, vibratory sense, discriminative touch, light touch. And these are known as A beta fibers because they're largely innervating cutaneous receptors. Note that all of these dorsal roots that are associated with the medial division enter and kind of sweep medial to most of the dorsal horn, because their major destination, in addition to participating in reflexes, is to send collaterals into one of our neural systems, which will form the dorsal columns. So it's really, in a major way, the proprioceptive fibers that are entering also into the intermediate zone or down into the ventral horn to participate in various reflexes. In contrast, note the difference with regard to the anatomy of the lateral division of the dorsal root. These fibers are thinly myelinated. They're known as A delta fibers, or unmyelinated. They're known as C fibers. These lateral division fibers are basically entering and synapsing mainly in the dorsal horn of the spinal cord in various laminae, and they are responding to the modalities of sharp pain, dull pain, cold, and warmth. The sharp pain and cold modalities are conveyed by the A delta fibers. The sensations of dull pain and warmth are being conveyed largely by the unmyelinated C fibers. But again, very different sites of termination with regard to after their point of entry into the spinal cord. All right, and then a final comment. Early on, we subdivided the gray matter of the dorsal horn of the gray matter of the spinal cord into a dorsal horn, a ventral horn, and an intermediate zone. Now, being a little more specific, we can organize these regions of the gray matter into a series of what are known as rexed laminae. The details aren't particularly important, just to the general terms. For example, The dorsal horn corresponds to Rectsed laminae 1 through 6, and in a major way, what's synapsing in the Rectsed laminae 1 through 6, parts of those laminae, will be the incoming lateral division fibers of the dorsal root. The ventral horn contains Rectsed laminae mainly 8 and 9. 9 is going to be more important because it will contain the cell bodies of axons that exit in a ventral root. The intermediate zone containing autonomic neurons and cerebellar sensory neurons is lamina 7. Now, by contrast, let's do the same thing by looking at the anatomy of a ventral root. The ventral roots largely arise from lamina 9 in the ventral horn, as we just indicated. And certainly the goal of a ventral root motor neuron, as we'll see, is to go out and innervate skeletal muscle. But note that there are actually two kinds of ventral root axons. The alpha motor neurons, as we'll see, will be the axons that exit in a ventral root and go out and innervate skeletal muscle at the neuromuscular junction and make it contract. Gamma motor neurons are much smaller diameter axons. Their cell bodies are still found in the ventral horn, mainly in lamina 9. Gamma motor neuron axons go out and innervate muscle stretch receptors, muscle spindles, and alter the sensitivity of that muscle spindle to muscle stretch. The other point that we want to make about the ventral horn is that the motor neurons in the ventral horn are not randomly situated. They are situated based on whether they innervate flexors or extensors, or whether they innervate proximal or distal musculature, particularly in an area of the spinal cord that's serving a limb. So on the left side of this diagram in the spinal cord, you see how the motor neurons are organized in the ventral horn, in that motor neurons that innervate flexors, particularly in the upper limb, are situated more dorsally. Motor neurons that innervate extensors are situated more ventrally. And also you can see that there is a proximal to distal gradient of innervation across the ventral horn, where proximal motor neurons that innervate trunk muscles are situated more medially. Motor neurons that innervate distal musculature, particularly in the upper limb involving hand muscles, are situated much more laterally. And again, as we indicated earlier, since we need many more lower motor neurons to innervate all the muscles of a limb, this is why in spinal cord segments from C5 to T1, we have what's known as an enlargement, a much larger lateral extension of the ventral horn. Now, since we've talked about the basic anatomy of the spinal cord, what we're going to do now are construct three fundamental neural systems that have components throughout the entire CNS, but that begin or end with either a ventral root of a spinal nerve or begin with a dorsal root of a spinal nerve. So these three neural systems are sensory and motor depending, and they have elements throughout the entire CNS, which means that elements of these three neural systems can be lesioned at many places in the CNS, beginning at spinal cord levels. So the first of these fundamental neural systems that begins or ends at spinal cord levels is a motor one. And this is a 2-neuron control mechanism by which we elicit voluntary contractions of skeletal muscle. And this 2-neuron pathway utilizes two neurons named the upper motor neuron and the lower motor neuron. These two neurons are synaptically related, and together they allow us to contract all skeletal muscle, limbs, trunk, everywhere, voluntarily. And as we'll see, the lower motor neurons are going to be the neurons whose cell bodies are in the ventral horn of the spinal cord and are in cranial nerve nuclei in the brainstem. And it is the axon of the lower motor neuron which will actually go to the neuromuscular junction of every skeletal muscle and make it contract. As we'll see, the axons of the upper motor neurons will be entirely contained within the central nervous system. What's shown on the next page is a highly schematic diagram of the entire central nervous system that's organized basically into a box. And what we've done here is use a dashed line to equally divide it into right and left halves. what we're going to illustrate is how we make a skeletal muscle on the left side of the limbs or trunk contract voluntarily, utilizing an upper and a lower motor neuron. First point we want to make is look where all parts of the lower motor neuron are situated relative to the midline of the CNS and relative to the skeletal muscle being innervated. The answer is all parts of a lower motor neuron are on the same side of the midline as the innervated skeletal muscle, which is an ipsilateral relationship. So all parts of a lower motor neuron are ipsilateral to their innervated muscle. But now, note where the cell bodies of the upper motor neurons are. They are on the opposite side of the CNS. In this example, the cell bodies of the most important upper motor neuron system are in motor cortex, precentral gyrus of a cerebral hemisphere. But since their cell bodies are on the right, they are contralateral to the lower motor neurons that they innervate, since the cell bodies of the lower motor neurons are on the left. So the cell bodies of upper motor neurons are contralateral to the lower motor neurons that they innervate. What that means is their axons must cross the midline somewhere, but before we get to that, we need to make two other points. First, we've already said that the lower motor neurons reach a skeletal muscle after exiting in a root of a spinal nerve and coursing in a ramus of that corresponding spinal nerve. So from now on, all of the axons in nerves, such as the median nerve, the ulnar nerve, femoral nerve, sciatic nerve, whatever, they are all axons of lower motor neurons. Cell bodies of the upper motor neurons are in motor cortex. Their axons must leave motor cortex, course down through the length of the brainstem and spinal cord, and since their axons are entirely contained within the CNS, their axons course in a tract. And the lateral corticospinal tract contains the axons, therefore, of the upper motor neurons. But we know that they have to cross the midline somewhere, and all of these axons cross at the same point. They cross at what is known as the pyramidal decussation. A decussation is an oblique crossing of axons. The word pyramid is a synonym for corticospinal tract. Note where the decussation is. It occurs very close to the medulla spinal cord junction. So this is a two-neuron mechanism that is utilized to make skeletal muscle, and this is example on the left, contract voluntarily. What else is shown in this picture is how we utilize two slightly different neurons to make skeletal muscle contract reflexively. So to make skeletal muscle contract reflexively, we have to stimulate receptors in the skeletal muscle. And the easy way to do that is to stimulate muscle stretch receptors. Muscle stretch receptors in skeletal muscle are known as muscle spindles. So when you stimulate a skeletal muscle by stretching it, you increase the activity of the muscle spindles, and by default, you increase the firing rate of the muscle spindle sensory fibers that innervate that muscle spindle. And as we know from the point when we looked at the dorsal roots, the muscle spindles are innervated by heavily myelinated Roman numeral 1A dorsal root sensory fibers that are entering in the medial division of the dorsal root. So they had a variety of places where they synapse. One of the things that these 1A fibers do upon entry is they sweep down directly into the ventral horn of that spinal cord segment and synapse directly with lower motor neurons. The activated lower motor neurons then make the stretched muscle contract reflexively. So here's the point. We have two ways actually of making skeletal muscle contract. We can make it contract voluntarily when we utilize an upper and a lower motor neuron. We can make skeletal muscle contract reflexively when we activate a muscle sensory neuron and the lower motor neuron. So the point is, lower motor neurons are needed under all conditions of muscle stretch. Next, let's look at the details of the various muscle reflexes. So on the left side of this picture is a basic way to stimulate muscle stretch by activating muscle spindles. This is to use a reflex hammer and, for example, bang on a tendon that belongs to a skeletal muscle, in this example, the patellar tendon. And when we do that, we stretch the quadriceps muscle and stimulate muscle spindles that are embedded in that quadriceps muscle. The other kind of reflex, although we don't stimulate it under normal neurologic circumstances, is known as an inverse muscle stretch reflex, and this is activated by an increase in muscle force that stimulates Golgi tendon organs that are embedded in the tendons of virtually all skeletal muscles. So if we look at the top part of this diagram, we can see the neural mechanisms involved in and/or activated by these two conditions. So this is the next view. First, on the left, we know that we stimulated a skeletal muscle on the left by increasing its length by stretching it by banging on a tendon. When we do that, as indicated here, we increase the activity of the muscle stretch receptors. They're activated by muscle stretch. And look what they do. They are innervated by 1A dorsal root fibers that enter in the medial division of the dorsal root. And among other things, one of the things they do is go into the ventral horn of the spinal cord, synapse directly on lower motor neurons that go out and make the quadriceps muscle contract reflexively. And by analogy, they also inhibit the antagonist muscles through an interneuron, causing the hamstring muscles, which are antagonists, to relax. On the right side of the picture are the two neurons, or the neurons that are activated when you increase muscle force and activate a Golgi tendon organ. Golgi tendons are innervated by 1B fibers. They also enter in the medial division of the dorsal root, and through an inhibitory interneuron, they cause an overactivated or over-contracting skeletal muscle to relax. So they provide, in essence, a protective mechanism to prevent muscle damage by generation of excessive force. So the 1B fibers innervate Golgi tendon organs. They cause a muscle-generating increased force to relax. A 1A fiber innervates a muscle spindle that basically causes a stretched skeletal muscle to contract reflexively. So this is kind of summarized here, where we know that in all conditions, whether we're stimulating muscles by stretching them or increasing their muscle force, we are activating or inhibiting alpha motor neurons. So again, alpha motor neurons really are the lower motor neurons that are components of all nerves that go out to the neuromuscular junction and make skeletal muscle either contract voluntarily or reflexively. And this makes the additional point, even though it wasn't shown on the diagram. Gamma motor neurons, cell bodies in the ventral horn, are part of a ventral root. Gamma motor neurons go out and innervate the muscle stretch receptors, the muscle spindles, and alter their sensitivity, generally making them more sensitive to the same kind or condition of muscle stretch. Now, what are the commonly tested muscle stretch reflexes? What muscles are being tested? And what are we testing the muscle sensory neurons and the lower motor neurons in terms of specific nerves? Well, at the top of the chart is the reflex that we just wired together, and that was known as the patellar tendon reflex, where we're banging on the patellar tendon or patellar ligament properly that extends from the quadriceps muscle down to the anterior aspect of the tibia. So in essence, when we bang on that tendon, we are stimulating the 1A and the lower motor neuron fibers of the femoral nerve, because we are testing, in essence, the reflex contractions generated by the L2, L3, and L4 spinal cord segments, and certainly the muscle that's being tested is the quadriceps. But there are a couple of others that are commonly tested. When you bang on the ankle, technically you're tapping on the Achilles tendon. You're stimulating the muscle sensory and the lower motor neurons in the tibial nerve, mainly in the S1 spinal cord segment, and you're causing a reflex contraction of the gastrocnemius muscle. So those are lower limb muscle stretch reflexes. Two that are commonly tested in the upper limb are the biceps tendon reflex and the triceps tendon reflex. When you bang on the biceps tendon, you are activating muscle sensory and lower motor neurons in the musculocutaneous nerve, mainly in the C5, C6 spinal cord segments, and you're causing a reflex contraction of the biceps and a reflex flexion of the forearm at the elbow. Triceps is the antagonist to that. When you bang on the triceps tendon, you are looking for reflex forearm extension by activating the triceps and stimulating the C7 and C8 spinal cord segments that make up the radial nerve. Less frequently tested would be the brachioradialis tendon, which would also cause a flexion of the forearm at the elbow by activating C5 and C6 fibers in that same radial nerve. Next, let's look at exactly where the axons of the lower motor neurons and the upper motor neurons course as they descend and exit from various segments of the spinal cord. So the upper part of this picture shows the location of the corticospinal tract after it has coursed through the entire length of the brainstem, and you're seeing that its axons are crossing at the medulla spinal cord junction at the pyramidal decussation. Then from there, the corticospinal tract has to descend the entire length of the spinal cord, contralateral to its decussation, but at every spinal cord segment, it must send axons into the ventral horn of the spinal cord gray matter, where the axons of the corticospinal tract will synapse on lower motor neurons that then exit horizontally from the spinal cord in a corresponding nerve that's innervating a muscle in a limb or a trunk, respectively. A better view of this is shown in the next picture, which is a similar extension view of the bottom end of the spinal cord, but it's valuable in the sense that it not only on the left side shows the longitudinal extent of the corticospinal tract and the fact that its axons again are peeling off to innervate lower motor neurons at lumbosacral cord levels that are innervating muscles of a lower limb. On the right side, you see two pictures of the spinal cord, and the important point to be made here is look where the axons of the corticospinal tract run in the lateral part of the spinal cord white matter throughout the length of the cord. So that's important to recognize where the axons of the upper motor neurons run in the white matter, because subsequently we'll have to distinguish this location from the axons of various sensory pathways that are found in other parts of the white matter. And again, the other point is the corticospinal tract is certainly the most important bundle of axons of upper motor neurons, but it's not the only one. There are other less important upper motor neuron systems that mainly have their cell bodies in various parts of the brainstem that participate in the innervation of smaller pools of lower motor neurons. And the other point about most of them, particularly the reticulospinal and vestibulospinal tracts, they tend to have an extensor bias, but they are providing a bilateral innervation of lower motor neurons, not a unilateral innervation, which is the case for the corticospinal tract. And that is significant because if I have an isolated lesion of a reticulospinal or a vestibulospinal tract, the patient is not going to have any signs and symptoms because of the bilateral innervation. Whereas if I lesion the corticospinal tract, I'm going to have distinct signs and symptoms because all of the lower motor neurons on the side of the lesion in the spinal cord are going to be deprived of their upper motor neuron innervation. All right, and then the last point that's made on this picture is the lesion strategy. Anytime we lesion a tract that is running either up or down through various parts of the CNS, the effects of that lesion will always be below the lesion. So in this example, we see an isolated lesion involving the corticospinal tract, and basically we're going to have a form of a weakness that we'll define subsequently that will be ipsilateral and below the lesion. Because when I lesion the corticospinal tract, I will have denervated all the lower motor neurons on the same side of the spinal cord below the lesion. So corticospinal tract lesions in the spinal cord result in a weakness that is ipsilateral and below the lesion. In contrast, if you lesion the axons of a lower motor neuron, the effects again will be ipsilateral, but the weakness will be seen ipsilateral and horizontal to or at the level of the lesion, because all of the axons of the lower motor neurons are exiting in nerves that exit horizontal to the spinal cord or out of it directly rather than descending below their point of exit. So all of the lesions involving upper and lower motor neurons in the spinal cord give us ipsilateral deficits, but the location is different. Corticospinal lesions, the effects are ipsilateral and below the lesion. Lower motor neuron lesions are always ipsilateral, but at or horizontal to the level of the lesion. On the previous slide, we pointed out that a lesion of either the upper or the lower motor neuron will result in a corresponding weakness or a decreased ability to make skeletal muscles contract voluntarily. But now we need to be more precise about what the other signs and symptoms are of a patient that has either an upper or a lower motor neuron lesion. So let's deal with the lower motor neurons first. As we've seen, We need the lower motor neurons under all conditions of skeletal muscle contraction. We need a lower motor neuron for voluntary contraction. We need a lower motor neuron for reflex contraction. And because of that, when patients have a lower motor neuron lesion, they're going to have a form of paralysis, decreased or absent ability to make skeletal muscles contract, but their skeletal muscle stretch reflexes will be suppressed or absent because of the loss of the motor limb of that stretch reflex. So kind of a hallmark of a patient with a lower motor neuron lesion is they will have paralysis because there's no way a denervated muscle can contract under any conditions, but the paralysis will classically be seen with suppressed or absent muscle stretch reflexes. So there are two terms that are used to describe this. Tone is an expression of the caliber of muscle stretch reflexes. So patients with a lower motor neuron lesion are typically those that have decreased muscle tone, hypotonicity, or hypo or areflexia, suppressed or absent muscle stretch reflexes. All of those are hallmarks of a patient with a lower motor neuron lesion. Next, assuming that the lesion is a serious one, for example, if you've transected the axon of the lower motor neuron, as the axon undergoes anterolateral degeneration, it causes fasciculations in the denervated skeletal muscles. Fasciculations are random twitches of denervated motor units that are visible beneath the skin. Later on, after the lower motor neuron axons degenerate, there will be significant atrophy or wasting away of the denervated muscles. So collectively, the sum and substance of signs and symptoms of a patient with a lower motor neuron lesion include paralysis, suppressed or absent muscle stretch reflexes, fasciculations, and atrophy. The global term that we use to describe all of those collectively for a patient with such a lesion is a patient with flaccid paralysis. Next, on the left side of this chart, compare those signs and symptoms with a different patient that has an upper motor neuron lesion. What we didn't point out, but we'll say now, is that we do not need the upper motor neurons under all conditions of muscle contraction. We only really needed the upper motor neurons during voluntary contraction of skeletal muscles. But upper motor neurons play a role in reflex activity. In essence, upper motor neurons act like a braking mechanism. They provide a net overall inhibitory effect on muscle stretch reflexes. They don't start them or actually stop them in their tracks, they just suppress them, they inhibit them. Meaning that when you have a patient with an upper motor neuron lesion, the muscle stretch reflexes will not only be present, they will be better than good, they will be hyperactive. So a hallmark of a patient with an upper motor neuron corticospinal tract lesion will be a weakness with hyperactive muscle stretch reflexes, hyperreflexia, or increased muscle tone. And we use the term typically to express upper motor neuron signs including paresis because the corticospinal tract is not absolutely the only upper motor neuron system. It's the most important, but patients generally with a corticospinal tract lesion are likely more to have a paresis, a weakness, than a total paralysis, if only because I can still make skeletal muscles contract reflexively in a patient with an upper motor neuron lesion because their reflexes are hyperactive. Next, in response or as side effect of the increased muscle tone is these patients will have what is known as a clasp knife reflex, where there is passive resistance to muscle contraction generated in a patient with an upper motor neuron lesion, but all of a sudden in response to increased muscle activity, the muscles will suddenly give way as if you're opening a penknife that constitutes the clasp knife reflex. So that's kind of a manifestation of an upper motor neuron lesion where the patient has increased muscle tone. Next, one of the classic signs of a patient with a corticospinal tract lesion, particularly one in an adult, is a Babinski sign. A Babinski sign is a backwards motor response to a cutaneous stimulus. And under normal circumstances, when you stroke the sole of anyone's foot, patient or otherwise, going from the heel to the toe with a relatively sharp stimulus, the toes will respond by flexing. That's a normal response to the cutaneous stimulus. When patients have an upper motor neuron lesion, the motor response to that same stimulus is backwards, in that when you stroke the sole of the foot with the cutaneous stimulus, instead of the toes flexing, the toes will extend and fan out, generating what's known as a Babinski sign. So the synonym for a Babinski sign is known as an extensor plantar response. That's a synonym which is characteristic of an adult patient that has an upper motor neuron lesion. And the reason we say adult is a presence of a Babinski sign bilaterally is normal in a newborn infant because the corticospinal tracts have not yet fully myelinated at birth. So the global term that's used to express all the signs and symptoms of a patient that has an upper motor neuron lesion that includes weakness, hyperactive reflexes, clasped reflex, and a Babinski sign is spastic paresis, spastic weakness. And we explored this earlier, but now the other issue we need to recognize is where do we get the weakness relative to a lesion? And again, looking back at this diagram, we have several lesions, A, B, C, D, and E, in various parts of upper or lower motor neurons. So let's do the lowers first because we know the answer to this. If we lesion any part of a lower motor neuron, destroy its motor neuron cell bodies, lesion its axon, the patient will have a flaccid paralysis with suppressed muscle stretch reflexes and the paralysis that is ipsilateral and at the level of lesion. But now we need to make a very important point because since the axons of the corticospinal tract cross, when we lesion the corticospinal tract, we're always going to have effects that are below the lesion, but they're going to change side depending on whether we've lesioned the corticospinal tract before it crosses or after it crosses. And that point is illustrated on this picture. If we destroy the cell bodies of upper motor neurons and motor cortex, or lesion the axons of upper motor neurons as they course through the brainstem before they cross, a lesion at A and B will result in a spastic weakness that is contralateral and below the lesion. In contrast, if we lesion the corticospinal tract anywhere in the spinal cord, for example at letter C, the effects will again always be below the lesion if we lesion a tract, but the spastic weakness will be ipsilateral and below the lesion. So we need to be sensitive about where the lesion might be in the upper motor neurons relative to the side of the deficits, and there will typically be in a neurologic case individual clues, additional clues, to tell you where the corticospinal tract has been lesioned. All right, so if you've gotten nothing out of the first part of our conversation, you've gotten this. How many neurons did it take to make skeletal muscle contract voluntarily? The answer was 2, an upper and a lower motor neuron. Now we need to deal with 2 sensory processing pathways that instead of using 2 neurons in our motor system, they utilize 3 neurons to convey different kinds of sensory modalities from sensory receptors in skin or muscle to conscious levels of cerebral cortex. And these 2 3-neuron pathways are illustrated in this chart. They are known as the dorsal column medial lemniscal system, and the other one is known as the anterolateral system. Both of these sensory processing pathways begin with dorsal roots in the spinal cord and utilize that dorsal root neuron and 2 other neurons to convey different modalities of sensation to conscious levels of cerebral cortex. For example, in both systems, neuron number 1, the dorsal root, is going to have its cell body in a dorsal root ganglion. Neuron number 2, the cell body of the second neuron, is going to be on the same side as the entering stimulus. But the axon of that second neuron, as we say in the chart, and we'll illustrate further, will cross the midline of the central nervous system in the vicinity of its cell body. The third neuron in both of these sensory processing systems will be in the thalamus in a specific thalamic relay nucleus. And second, you can see the modalities of these individual systems that they're conveying. Dorsal column medial lemniscal is conveying the discriminative touch modalities, including touch, 2-point discrimination, vibration, and pressure, and along with that, conscious proprioception, your awareness of where muscles are in space. The anterolateral system, as you can see, is conveying the modalities of pain and temperature. And again, further details about both systems are illustrated here. Again, we're looking at the location of the 3 neurons that are going to be in a similar form and location in these three systems. Again, the first neuron is going to be the dorsal root, innervating the sensory receptor cell body of the first neuron in the dorsal root ganglion. The central process of that dorsal root will enter the brain, and its goal in life is to find the second neuron cell body, which we point out is ipsilateral to the cell body of the first neuron. But again, the significant feature is this. The axons of second neurons in sensory processing pathways cross the midline in the vicinity of their cell body. Once they cross, they coalesce and run in a tract or a lemniscus up to higher levels of the central nervous system. Their goal is to find neuron number 3. Neuron number 3 will be in the thalamus, and then the axon of the third neuron will project to primary somatosensory cortex, where we perceive the nature of the sensory stimulus. All right, so on the next slide, let's look at the details. What are and where are the 3 neurons that are processing the discriminative touch modalities as part of the dorsal column medial lemniscal system? So first off, again, function of the system includes the modalities of conscious proprioception, discriminative touch, vibratory sense, pressure sensations, two-point discrimination, and fundamentally the receptors that are responding to those modalities tend to be encapsulated, specialized. For example, Pacinian corpuscles are responding to vibratory sense. Meissner's corpuscles are specialized touch receptors in the underlying dermis adjacent to the epidermis. But look what other sensation is part of the system. Muscle position sense, muscle stretch, generated and being responded to by our muscle spindle sensory fibers that basically were innervating muscle spindles in all skeletal muscles. So again, first neuron of this 3 neuron set basically is in the dorsal root ganglion. These fibers are entering in the medial division of the dorsal root. And the reason they're doing that is they're going to look for second neurons that are nowhere to be found in the spinal cord, which is why their entering point is medial to the entire dorsal horn, because the second neurons that are responding to this sensory input are not found anywhere in the spinal cord. So what has to happen is the central process of the first neuron in this pathway is going to be very long, and it's going to turn upward from its point of entry and run in a tract the entire length of the spinal cord from its point of entry. And the tracts in the spinal cord white matter that carry the central processes of this first neuron are known as the dorsal columns. And there are 2 dorsal columns whose anatomy is illustrated on the slide. One of them that runs the entire length of the spinal cord from its point of entry is the fasciculus gracilis. This starts collecting the touch modality proprioceptive information from sacral and coccygeal dermatomes and collects it all the way up until we get to the T6 dermatome at mid-thoracic levels. Then from there, the fasciculus gracilis no longer collects such information, but merely courses through the upper thoracic and cervical spinal cord on its way into the brainstem. Beginning at T5, we see the appearance of a second dorsal column, known as the fasciculus cuneatus, that begins to collect the same kind of sensory information from the dermatomes beginning at T5 up and including the upper limb. And since this information is entering a little later, the cuneatus is always lateral to the fasciculus gracilis. Anyway, these axons of the first neuron are very long because they have to run up the entire length of the spinal cord from their point of entry. Their site of synapse with neuron number 2 is in the caudal medulla, and the location of those second neurons are a nuclei that match the dorsal column that synapses there. The fasciculus gracilis synapses in the nucleus gracilis. The fasciculus cuneatus synapses in the nucleus cuneatus. That occurs in the caudal medulla. Then, following the rule, the axons of that second neuron leave those dorsal column nuclei, cross the caudal medulla in the vicinity of their cell body, and after they cross, they coalesce to form an axon bundle of the second neuron that's called the medial lemniscus. The medial lemniscus then tracks through the length of the brainstem on its way to synapse with third neurons that are in the thalamus. The thalamic relay for body somatic sensation is VPL, the ventral posterolateral nucleus of the thalamus. And from there, the third neuron projects to conscious levels of cerebral cortex so we can perceive the nature of the touch stimulus. So that's the 3-neuron pathway that's involved in the dorsal column medial lemniscal system. So now, lesion strategy. Where are we going to see the loss of vibratory sense, for example, if we have a lesion of a dorsal column anywhere in the spinal cord, including part of its course in the caudal medulla? The answer of a lesion at D will be a loss of touch vibration and pressure that is ipsilateral and below the lesion. Because again, we're lesioning a tract that's running longitudinally through the central nervous system. In contrast, if we lesion any part of the neural system that has crossed the midline, including the medial lemniscus anywhere in the brainstem, the thalamic neuron or somatosensory cortex at A, B, or C, now the deficits will be contralateral and below the lesion. So again, I'm going to need some additional information in a neurologic case to tell me whether I've lesioned a dorsal column, resulting in an ipsilateral loss, versus something higher, medial lemniscus or the thalamic neuron, which is going to result in the same loss, but it's going to be a contralateral loss below the lesion. So that's the first of our 3 neuron systems that's conveying the modalities of discriminative touch, vibratory sense, pressure, conscious proprioception, and so on. Now, let's look at specifically where these neural elements are found in a series of spinal cord sections. So on the left side, we're illustrating a longitudinal view of the spinal cord where we're showing primary sensory neurons from the dorsal root entering in the form of 1A, 1B, or class 2 fibers. They're entering in dermatomes that are serving the lower limb, basically from T6 down. And because we know that the second neuron is not to be found anywhere in the spinal cord, you can see that all of these central processes of neuron number 1, the dorsal root, have to turn and run longitudinally up through the entire length of the spinal cord. In this case, from the lower dermatomes, they will course in the fasciculus gracilis. So you see them coursing up there. And then if you look over at the corresponding spinal cord sections, you can see exactly where the dorsal column axons run. As they're logically named, they run in the dorsal part of the spinal cord white matter. And over on this diagram on the right, you can see that, among other things, if it is a proprioceptive neuron that's contributing to conscious proprioceptive sensation in the dorsal column, yes, it sends collaterals up in the fasciculus gracilis, but as we know, those muscle spindle sensory fibers are also participating in muscle stretch reflexes by participating in a reflex synapse with a lower motor neuron. So it is collaterals of that muscle spindle, along with the touch modality fibers, that are sending collaterals into the fasciculus gracilis. Then if we do the same thing by looking at the upper part of this diagram, we can see some dorsal roots, first neurons entering from the upper limb and coursing in the more laterally positioned fasciculus cuneatus. And note that the gracilis is still present in upper spinal cord levels, but it stops collecting information at basically about the T5, T6 dermatome. Then you can see that both dorsal columns ascend up to the lower medulla, where they find and synapse with neuron number 2 in the corresponding dorsal column nuclei, either the cuneate nucleus or the nucleus gracilis. Then in the vicinity of their cell body, as you can see in the diagram on the right as well as on the left, the crossing axons cross the midline of the medulla in the vicinity of their cell body, and in doing so they form what are called internal arcuate fibers. Once the fibers coalesce on the opposite side of the caudal medulla, they form the medial lemniscus that basically represents the crossed axons of the second neuron in this pathway. And then we know that the medial lemniscus' goal in life is to reach the third neuron. The third neuron is in the VPL nucleus of the thalamus, and then the thalamic neuron projects to primary somatosensory cortex. So that's the first of our 3 neuron sensory processing pathways that begins with a specific modality sensation that activates a population of dorsal root ganglion cells at spinal cord levels. The other 3 neuron sensory processing pathway that begins at spinal cord levels is known as the anterolateral system. And the functions of the anterolateral system are to convey the sensations of pain and temperature from the limbs and trunk to conscious levels of cerebral cortex. Again, the anatomy and the and the locations generally of these three neurons are the same. The major difference is in where the cell body of neuron number 2 is situated in this 3-neuron pathway. So we start out as before by having a dorsal root respond to a pain and temperature stimulus and carry that sensation in to the spinal cord in the dorsal root of every spinal nerve. The major difference here is that the first neuron that's processing pain and temperature is very short, because within a segment or two of entry into the spinal cord, this first neuron goes down into the dorsal horn of the ipsilateral side of the cord and finds and synapses with the second neuron. So the first neuron only has to ascend, or in some cases descend, 1 to 2 segments after its point of entry in the spinal cord, and the short course, the axons of this first neuron, are said to course in what's known as Lissauer's tract. Note that the cell body of the second neuron is ipsilateral to the first neuron, and as we said, within a segment or two of the point of origin of that first neuron. Now, following the rule, the axon of the second neuron must cross in the vicinity of its cell body, and it does so. And once those axons cross the midline at all levels of the spinal cord, they coalesce to form the spinothalamic tract. So the spinothalamic tract is analogous to the medial lemniscus in our other 3-neuron sensory processing pathway, in that both tracts represent the axons of second neurons that have crossed the midline. So as the name implies, the next stop of the spinothalamic tract is to synapse on third neurons that are situated in the thalamus, VPL, and then, like the DCML system, the axons from the thalamic neurons project to conscious levels of subcerebral cortex. But now, very different clinical neurology. Because the pain and temperature sensations enter the spinal cord and cross so soon after entering, virtually any lesion involving a component of the anterolateral system results in a loss of pain and temperature that is contralateral and below the lesion. Only if you lesion that first neuron within a segment or two of its point of entry will you get an ipsilateral dermatomal-based loss basically within that territory, whereas every other lesion at A, B, C, or D on this page is going to result in a loss of pain and temperature that is contralateral and below the lesion. And again, as before, let's look specifically in spinal cord sections as to where the components of the anterolateral system are situated. On the longitudinal figure on the left, we see the axons of first neurons conveying pain and temperature, entering as central processes of dorsal roots from the more inferior dermatomes. They enter the spinal cord and ascend 1 to 2 levels before finding and synapsing on the cell bodies of neuron number 2 that's in the ipsilateral dorsal horn. And then from there, following the rule, the axons of that second neuron must cross the midline. But look over at the diagram on the right. In these two cross sections, you can see precisely where the axons of that dorsal horn neuron are crossing the midline. Not only is the crossing point in the vicinity of its cell body, it's crossing right through the center of the spinal cord, just below the central canal of the spinal cord, which is right in the middle. And then after the axons cross, they coalesce to form the spinothalamic tract that then ascends the length of the spinal cord in the ventrolateral spinal cord white matter on its way to the thalamus. In a similar picture at the upper spinal cord levels, we can again see primary sensory neurons conveying pain and temperature entering now from the upper limb, coursing up 1 or 2 segments in Lissauer's tract, synapsing with second neurons, in this case in cervical spinal cord, axons crossing in the vicinity of their cell body, coalescing to form the spinothalamic tract, projecting to thalamus and projecting to cortex. So the last point we want to make is when we have a complete lesion of the spinothalamic tract, for example at spinal cord levels, the loss of pain and temperature will certainly be contralateral, but it's going to begin 1 to 2 segments below the lesion because it took 1 to 2 segments for the first neurons to get up and synapse in the last axons that will join the spinothalamic tract just below its lesion. Next, we need to deal with two two neuron sensory processing pathways that are not as obviously as important for conscious sensation, but they provide important sources of sensory input to the cerebellum. And as such, we term these two pathways sources of what is known as unconscious proprioception, meaning that proprioceptive input that the cerebellum uses to fine-tune skeletal muscle contractions, but not a form of proprioceptive sense that we perceive consciously. So these are two neuron pathways that project to the ipsilateral cerebellum, and again, they begin with a sensory process of a dorsal root ganglion cell that's innervating either a muscle spindle or a Golgi tendon organ. So what's illustrated here are the 1A fibers coming from muscle spindles, and what you can see is, for conveying muscle position sense, they enter the spinal cord, and depending on whether they come from the upper limb or the lower limb, they're either going to synapse in Clark's nucleus, which is in the intermediate zone of the gray matter of the cord from T1 to L2, or if they're coming from the upper limb, they're actually going to synapse in a brainstem nucleus called the external cuneate nucleus. Regardless, the goal of Clark's nucleus and the external cuneate nucleus is to form a cerebellar tract, dorsal spinal cerebellar coming out of Clark's nucleus, cuneo-cerebellar coming out of the external cuneate nucleus. Both of them enter the inferior cerebellar peduncle and fan out and serve the ipsilateral cerebellar cortex with proprioceptive information. So, although unlikely, isolated lesions that involve these spinothalamic tracts may occur, and they're usually linked to a group of hereditary diseases in which degeneration of one or both of them is a feature. The most common is Friedreich's ataxia, and this gives us a clue as to what the most common symptom of this degenerative disease will be. Since you are depriving the cerebellum of its sensory or proprioceptive input, the most common symptom of this degenerative process will be ataxia of gait. And this will be a form of what is known as a sensory ataxia, where the patient doesn't exactly know where their limbs are in space. They don't have any weakness, but basically they're going to walk with a broad-based gait without order just because they do not any longer know where their lower limbs are in space. Now that we've laid out the fundamental anatomy of the three neural systems that have components that begin and end at spinal cord levels, it's important to be able to recognize generally where you are in a specific spinal cord section. You don't need to know all the details, but you do need to recognize, if presented with a diagram or a histologic section, are you in cervical cord, lumbar, thoracic, or sacral cord, respectively? And there are a couple of questions that are fundamental ones that will help you figure out where you are. Number one is, does the cord section you're looking at have a large ventral horn? If so, that cord section has to be part of either the cervical or the lumbosacral enlargement because it contains significantly more lower motor neurons that are innervating limb musculature on a corresponding side. So if the answer is yes, cervical enlargement is C5 through T1 or L2 to S2, or if it's no, you're obviously in thoracic cord or in upper cervical cord, respectively. Next question is, are one or both dorsal columns present? We know that the fasciculus gracilis is going to be present at all spinal cord levels. So at a minimum, we're always going to have one dorsal column. But only above the T5 spinal cord segment will we have both a fasciculus gracilis and a fasciculus cuneatus. Sometimes it's difficult to tell whether both are present. So if both are present, basically they have to be obvious. There's usually a little indentation or a sulcus that separates the cuneatus from gracilis when both are present. And then finally, kind of a collateral issue is, but it's helpful as we'll see, is there a lateral horn present? The lateral horn represents a lateral extension of the intermediate zone of the spinal cord, and it's prominent from levels only between T1 and L2 because it contains preganglionic sympathetic neurons and Clark's nucleus. So if a lateral horn is not present, you're either above T1, cervical spinal cord levels, or below L2, basically at lower lumbar or sacral levels. So using these criteria, let's evaluate the sections that are shown on the next two slides. For example, we know this is cervical, aside from the fact it says cervical on the slide, because it has a very large ventral horn and it has two dorsal columns. The only place in the spinal cord where we would have this similar anatomy is somewhere between C5 and C8. If this were T1, it would have the same features as this section, but it would also include a lateral horn, which is not shown here. Then, the section that's second on the page is a thoracic one. We know better than that it has to be upper thoracic. Number one, because it has a very thin ventral horn, meaning it's not innervating a limb. Number two, it has a prominent lateral horn, which means it must be somewhere between T1 and L2, but not T1 because that's cervical enlargement. But because of the presence of two dorsal columns, that line there separating the dorsal columns indicates the presence of both the gracilis and the cuneatus. Our best answer for this is somewhere at upper thoracic levels, somewhere probably between T2, T3, or even T4. The other point we want to make, again, is an important one, and that is in all of these sections, note where the long neural system components are found. Note that the corticospinal tract is going to be found at every cord level and is going to be situated in the lateral part of the spinal cord white matter. The dorsal columns, one or both, are certainly going to be in a corresponding position in the dorsal part of the white matter. And the spinothalamic tract also has to be present at every spinal cord level in the ventrolateral white matter. And certainly every cord level is going to have dorsal horn neurons that respond to pain and temperature and lower motor neurons in a corresponding ventral horn. Lastly, let's look at the next page because it'll illustrate lumbar and sacral cord levels. The picture at the top of the page we say is lumbar, but we know again that it has a large ventral horn, meaning it's part of an enlargement, but it only looks as if there's one dorsal column present. So that means this could only be somewhere in the lumbar enlargement, somewhere between L2 and L5, and that's as specific as you can get. Sacral spinal cord levels have very different arrangement. At sacral cord levels, there's proportionally much more gray matter than white matter. Again, we might have a large ventral horn because of sacral involvement of the lower limb, but again, only one dorsal column. And aside from that fact, we're still going to have equal representation of all of our major neural system components in the similar positions in the white or the gray matter. Now, let's take our collective information about the spinal cord and review them briefly in a longitudinal section that contains elements of all three systems, and then create a hypothetical lesion that is going to be a spinal cord hemisection that lesions components of all three of our fundamental neural systems, and talk about the patient's signs and symptoms. What we're going to be describing will be the clinical neurology of a Brown-Séquard syndrome patient, a patient who has suffered from a spinal cord hemisection at a given level of the cord. Now, again, for example, we can see in this particular picture, first off, we could see lower motor neurons exiting horizontally at various levels of the spinal cord, going out to innervate the upper limb, the lower limb, trunk muscles, what have you. And we can also see what's driving them. We can see the axons of the upper motor neurons arising from a cell body at the top of the picture. Their axons crossing at the pyramidal decussation above the spinal cord. And then the axons descending down the length of the cord in the corticospinal tract, but sending axons peeling off that tract at every spinal cord level to enter the ventral horn and synapse on the lower motor neurons. So that's our two-neuron motor pathway. In addition, down at the lower part of the diagram, we can see the components of a muscle stretch reflex and how a muscle spindle sensory fiber, a 1A fiber, when stimulated by stretch, enters the spinal cord and synapses directly with the lower motor neuron, the alpha motor neuron, which generates a reflex contraction of that corresponding skeletal muscle. And lastly, we can also see one of the features we've already pointed out, and that is that muscle spindle sensory fiber, that 1A fiber, in addition to participating in muscle stretch reflexes, also can synapse in Clark's nucleus and be part of a two-neuron pathway that conveys unconscious proprioception to the ipsilateral cerebellum. Then the two sensory processing pathways. Beginning down at the bottom of the picture on the lower right, we see a primary sensory neuron that's responding to touch, vibration, and conscious proprioception. The The central processes of its dorsal root axon are entering in the form of a 1A or 1B proprioceptive fiber. Class 2 or A beta fibers are responding to the touch modalities regardless. These fibers enter, in this case at sacral spinal cord levels, but they must ascend the entire length of the cord in the fasciculus gracilis from their point of entry until they reach second neurons in the medulla, in this case the nucleus cuneatus, where they synapse. And then the axons of the nucleus cuneatus cross in the vicinity of its cell body, coalesce in the brainstem to form the medial lemniscus. Now let's look at, in the same figure, how the spinal cord is processing or utilizing the components of the sensory systems. Down on the lower right part of the figure, we see an incoming sensory neuron that's responding to the modalities of vibratory sense, touch, and conscious proprioception. And these, as we know, are the 1A, 1B, or the class 2 or A beta fibers. And since they are entering basically at sacral spinal cord levels, they have to ascend in the fasciculus gracilis from their point of entry all the way through the length of the cord itself until the fasciculus gracilis reaches and synapses in the nucleus gracilis that's found in the caudal medulla. Then from there, the axons cross in the vicinity of their cell body above the spinal cord, form the medial lemniscus that goes to thalamus and then cortex. The other 3 neuron sensory system has 2 of its neurons, as we know, at spinal cord levels. And this is the anterolateral system, the major component of which that runs the length of the spinal cord from point of entry is the spinothalamic tract. So the spinothalamic tract, as we know, represents crossed axons of a second neuron whose cell body is on the opposite side of the cord from where the tract runs. So down in the lower left side of this figure, we see a second neuron that's part of the spinothalamic tract system that's found in the opposite dorsal horn. And we also see a very short first neuron conveying pain and temperature that enters, goes up a segment or 2 before synapsing on that second neuron. Now that we've outlined the fundamental anatomy, let's create a hypothetical spinal cord hemisection, Brown-Séquard syndrome, by talking about the clinical neurology of a specific hemisection in the T10 spinal cord segment. So, what we've done with a hemisection is destroy or lesion components of all 3 of our fundamental neural systems. So this patient is going to have signs and symptoms attributable to a sensory loss in both sensory systems and a motor problem in the motor system, and here are the details. First off, we have certainly lesioned the corticospinal tract at T10. So what will the patient have in terms of a weakness? If I lesion the corticospinal tract anywhere in the spinal cord, in this case at T10, we know that the effects of the lesion will result in a spastic weakness that is ipsilateral and below the lesion. And since the lesion is at T10, it will only be the ipsilateral lower limb that will have weakness with hyperactive reflexes and obviously the Babinski sign. So a corticospinal tract lesion in this case will result in a lower limb weakness that is ipsilateral and below the lesion. Number 2, we've also lesioned the fasciculus gracilis at T10. So in this case, the patient will have an ipsilateral loss of touch and vibration sensations in all dermatomes, ipsilateral and below the lesion, beginning about the level of the T11 dermatome. So at the outset, in a spinal cord hemisection, we have what are known as 2 ipsilateral long tract signs, an ipsilateral spastic weakness below the lesion and an ipsilateral loss of vibratory sense in dermatomes below the lesion. Now, what are we going to see if we've also lesioned the spinothalamic tract at the level of the T10 spinal cord segment? Now we're going to have a loss of pain and temperature that is contralateral and begins 1 to 2 segments below the lesion. So the pain and temperature loss is the only neurologic sign or symptom that in a spinal cord lesion such as this is contralateral and below the lesion. All right, rhetorical question. Will this same patient have any ipsilateral loss of pain and temperature, and will they have any flaccid weakness at all? The answer to the ipsilateral loss of pain and temperature is yes. They will lose a little bit of ipsilateral, they'll have a little bit of ipsilateral loss of pain and temperature at or just below the level of the lesion, because we will have lesioned the incoming dorsal roots that are carrying pain and temperature into the T10 spinal cord segment. So the patient's going to have a little dermatomal loss of pain and temperature ipsilateral and at the level of lesion, whereas most of the significant pain and temperature loss is contralateral and below the lesion. And second, the answer to the other rhetorical question is, yes, there's likely to be a little bit of flaccid paralysis at the level of the lesion, because it's impossible to have a complete spinal cord hemisection that doesn't lesion some lower motor neurons ipsilateral and at the level of lesion. So the patient is likely to have a little bit of weakness in the T10 myotome, which obviously is part of the trunk, whereas most of the much more significant weakness is spastic and is basically in the lower limb below the lesion. Lastly, we've certainly lesioned, in this example, the dorsal spinocerebellar tract that's emanating out of neurons in Clark's nucleus. But this patient won't have any signs and symptoms of that because the ipsilateral lower limb is already undergoing a spastic weakness. So the spastic weakness is going to mask whatever signs and symptoms, the ataxia, that we would see if the dorsal spinocerebellar tract were lesioned all by itself. What's shown beginning on this page are examples of the 7 commonly seen and or tested spinal cord syndromes or degenerative diseases that include, as one of the 7, Brown-Séquard syndrome, which we've already discussed. And the point is, the way we've illustrated these is we've shown various spinal cord sections and indicated by the shading where there is unilateral or bilateral neuronal degeneration or the presence of a lesion that commonly results in some kind of spinal cord dysfunction. Now, what we do have to say is all of these spinal cord diagrams illustrate the same spinal cord section level. And as we discussed before, these all look like they are lower cervical spinal cord sections in the area of the cervical enlargement. But having said all that, we need to be careful and point out that not all of these spinal cord syndromes and diseases happen at cervical spinal cord levels. So we'll be precise about where they are more commonly seen. Starting with the first one. As indicated by the shading on this slide, this patient is suffering from a bilateral degeneration, certainly of lower motor neurons in both ventral horns. And this is a classic lesion that presents as poliomyelitis, and certainly all of the signs and symptoms are going to be emblematic of a bilateral flaccid paralysis patient with suppressed or absent muscle stretch reflexes, fasciculations, and atrophy, assuming the degeneration pattern is complete. Note that poliomyelitis much more commonly occurs at lumbosacral cord levels and only very rarely at lower cervical levels, as is indicated on the presence of this diagram. Next, very interesting case that looks at face value not terribly complicated, because certainly what is degenerating here bilaterally, this is a demyelinating disease, are the axons in both dorsal columns. So the first point we need to make is this lesion, this degeneration pattern, much more commonly occurs at lumbar cord levels than it does, as indicated, at lower cervical levels. All right, so this is a patient with late-stage neurosyphilis that presents with tabes dorsalis. And since this is a progressive demyelinating disease, we don't suddenly have a loss of function conveyed by the dorsal columns. We have a progressive altered sensation that might ultimately result in a complete dorsal column lesion. So neurologists use 3 words to describe some of the signs and symptoms that are emblematic of a patient with tabes, and they are paresthesias, pain, and polyuria. The paresthesias obviously represent altered vibratory pressure or light touch discriminative modalities. That obviously are the function of the axons in the dorsal column. But what happens is the pain neurons in the anterolateral system are not necessarily degenerating because they are not as completely myelinated, but they become hypersensitive to a touch stimulus. So these patients perceive a touch stimulus, particularly in the lower limbs, as being a painful one. Second, for unknown reasons, the sensory neurons that mediate bladder fullness are also demyelinating in this patient. So this patient doesn't know when their bladder is full. So they respond to that one of two ways. They can either increase urine output and have polyuria because they don't know when their bladder is full, or conversely, they could retain urine and have urine retention, again, because they don't know when their bladder is full. We just use the term polyuria because it fits the other two P-named signs and symptoms that are emblematic of a patient with tabes dorsalis. Next, in addition to the paresthesias, pain, and polyuria, look how this patient presents. Note that in the diagram, we have shown that not only are the axons of the dorsal column degenerating at lumbar levels, which means this is a bilateral demyelination of both of the fasciculus gracilis columns, but recognize that the axons in a dorsal column are the central processes of dorsal roots. And since proprioceptive sense, the 1A fibers, are part of the dorsal columns, note that what is also going to be affected will be the collaterals from those muscle sensory neurons that project down, as we see in the diagram, and provide the sensory limb of muscle stretch reflexes. So a patient with tabes dorsalis is likely to have suppressed or absent muscle stretch reflexes, not because they have a lower motor neuron lesion, but because in this case we have lesioned the sensory input to those reflexes. Next, this patient is likely to walk with a broad-based gait because, again, we've lost the proprioceptive input that's being conveyed by those muscle spindle sensory neurons. So this patient is said to have a sensory ataxia, where we are depriving the conscious levels of cortex as well as the cerebellum of its proprioceptive input. So even though this patient does not have any lower limb weakness, they do not know where their lower limbs are in space. And as a result, they will walk with a broad-based sensory ataxic gait. In addition, when you deprive the cerebellum particularly of its sensory input, patients will present with a Romberg sign. A Romberg sign basically is seen when a patient sways back and forth only with their eyes closed. Because when the patient has their eyes open, the cerebellum, which is intact, can use visual cues to help the patient maintain their balance. So in addition to having paresthesias, pain, and polyuria, this patient has sensory ataxia when they walk, and they have a Romberg sign. Last but not least, for some unknown reason, in a totally separate area of the central nervous system, there are axons degenerating in a region of the rostral brainstem called the pretectal area. And this area of the central nervous system contains neurons that link the pupillary light reflex neurons together. They link the optic nerve axons with the ocular motor axons and allow you to constrict your pupils bilaterally in response to light. A patient with Argyll-Robertson pupils will have a suppressed pupillary light reflex, but the accommodation convergent reaction will be normal. And one of the theories behind this is that there are more axons that are participating in the near response than are the axons that are participating in just the light reflex. So Argyll-Robertson pupils are pupils that accommodate normally in response to a nearly approaching stimulus, but are less or unreactive to a light stimulus in terms of pupillary constriction. So all of these signs and symptoms constitute what makes up tabes dorsalis, a late-stage manifestation of neurosyphilis. On the next page, we see two more. Next, at the top of the page is again a bilateral degenerative disease that affects not just the lower motor neurons bilaterally, as we saw in a case of poliomyelitis, but also results in a simultaneous bilateral degeneration of axons of the upper motor neurons. And again, this is the first section that works because this pattern of pure motor degeneration bilaterally is emblematic of a patient with amyotrophic lateral sclerosis that is common, as illustrated by the slide, by the section, in the cervical enlargement. And based on that location, the signs and symptoms make sense because we're seeing degeneration of the lower motor neurons in the cervical enlargement. So this patient is very likely to have flaccid paralysis, suppressed or absent muscle stretch reflexes in upper limb musculature. But since the corticospinal tracts are being lesioned in the area of the cervical enlargement, the spastic weakness and the elevated tone and reflexes will be seen bilaterally below the cervical enlargement, most emblematic in the lower limbs. So because of the specific location of the degeneration is why we see flaccid paralysis bilaterally at the level of the lesion, cervical enlargement, where we see bilateral spastic weakness present in the lower limbs below the lesion. So this is a pure bilateral degenerative pattern that affects upper and lower motor neurons, most commonly in the area of the cervical enlargement. Next, a blood supply issue. The major blood supply to the bulk of the spinal cord is provided by the anterior spinal artery. It's labeled ASA, and basically it is a blood vessel that is situated in the ventral midline, and as such, it provides the arterial blood supply bilaterally for the ventrolateral 2/3 of the spinal cord. So when there is a vascular insult or an occlusion of the anterior spinal artery, it most commonly occurs at mid-thoracic levels, and it results in a bilateral lesion of the corticospinal tracts, the lower motor neurons at the level of the infarct, and a bilateral lesion of the spinothalamic tracts. So assuming this is occurring at mid-thoracic levels, this patient is going to have bilateral spastic weakness in the lower limbs, but they're also going to have a bilateral loss of pain and temperature in the dermatomes below the lesion. What will be spared exclusively and only will be vibratory and pressure senses, because the dorsal columns are served by a pair of posterior spinal arteries and not the anterior spinal artery. So we kind of say that this patient has the same pattern of motor loss as a patient with ALS, in that they're going to have some flaccid paralysis bilaterally at the level of the infarct, bilateral spastic weakness below the infarct, but they're also going to have a bilateral sensory loss, and in this case it will be a loss of just pain and temperature bilaterally below the lesion. Next is, again, a demyelinating disease. This demyelinating disease results from commonly antibodies raised against intrinsic factor. And without intrinsic factor, which is essential for life, patients cannot absorb vitamin B12 from the terminal part of the ileum. And as a result, they have misshaped red blood cells, as well as demyelination of some of the large, heavily myelinated tracts that run through the spinal cord. And they include the dorsal columns. That can occur basically at anywhere. It occurs more commonly at lower cervical or upper thoracic cord. But in addition to having a bilateral dorsal column demyelination, these patients also tend to have demyelination of the corticospinal tracts as well as the spinocerebellar tracts. So they're likely to have signs and symptoms for a period of time similar to a patient with tabes dorsalis, where they'll have altered sensations of touch, vibration, and pressure below the lesion, depending on where the lesion is. But in addition, instead of having an ataxic gait, this patient is not walking at all because they're going to have bilateral spastic weakness and hyperactive reflexes everywhere below the lesion, presumably bilaterally present in the upper limbs. Next, classic case. And this is a case where we've alluded to it earlier in this review process, where there is a progressive enlargement or a cavitation of the central canal of the spinal cord. And this is a patient that is developing syringomyelia. It may be a side effect of a patient that had Arnold-Chiari type 2 malformation and the related hydrocephalus, but it can occur in isolation. When it occurs in isolation, it typically occurs in the area of the section that's indicated on this page, in the area of lower cervical spinal cord. So note what is going to be the initial presenting signs and symptoms in this patient. The syrinx is enlarging the central canal of the spinal cord. And remember which axons of which neural system are crossing bilaterally just below that central canal as illustrated on the diagram. The answer is the axons that are arising from the dorsal horn neurons that are beginning to form after crossing The next section that we're going to cover in some detail is a very important one in terms of clinical neurology, and this is in Chapter 5, the brainstem. Certainly, the brainstem is going to be the home of most of the cranial nerves, so this is where we'll deal with their detailed clinical anatomy. Fundamentally, the brainstem is divisible into three parts. They are the midbrain, the pons, and overlying the pons will be the cerebellum, which we'll talk about later, and the medulla. The midbrain basically begins just below the diencephalon. It's its own brain vesicle. The pons is in the middle, as we said, is overlain by the cerebellum. The medulla is the most caudal portion of the brainstem, and it's continuous with the spinal cord. As we said, the brainstem is important for a variety of reasons, the major one of which is it is the home of the nuclei, the sites of termination or origin of the fibers of 9 out of the 12 cranial nerves. The only cranial nerves that are not brainstem cranial nerves will be cranial nerves 1, the olfactory, 2, the optic nerve, and cranial nerve 11, the accessory, which is really a misplaced cervical spinal nerve because its motor fibers arise from cervical spinal cord. Then here is the organization, which we'll then look at a diagram of. And it's important to recognize what parts of the brainstem are giving rise to which cranial nerves. For example, and there's going to be a linear organization to this, as we will see. 2 of the cranial nerves, cranial nerve 3, the oculomotor, and cranial nerve 4, the trochlear nerve, arise from different parts of the midbrain. 4 cranial nerves, trigeminal, abducens, facial, and vestibulocochlear, cranial nerves 5, 6, 7, and 8, basically enter or exit from various parts of the pons. The last 3 brainstem cranial nerves, the glossopharyngeal, vagus, and hypoglossal, are the medulla cranial nerves. And as we've already indicated, the fibers of the accessory nerve, even though it is cranial nerve 11 because it exits through a hole in the skull, is really a misplaced cervical spinal nerve arising from cervical spinal cord. One of the more important points that we will add to this is not only is it important to recognize which cranial nerves arise from various parts of the brainstem, but as we note down at the bottom of the slide, note that the purely motor cranial nerves 3, 4, 6, and 12, exit from the medial aspect of the brainstem, whereas the mixed cranial nerves exit or enter from the lateral parts of the brainstem. And this is important because most of the commonly caused brainstem lesions are vascular insults. And as we'll see, we will divide those vascular syndromes into either lateral vascular syndromes that will typically involve a mixed cranial nerve or medial vascular syndromes involving the brainstem, which would involve a purely motor cranial nerve that's exiting close to the ventral midline. So with that organizational basis, let's now look at 2 views of the brainstem. A dorsal view is on the left side of the screen, a ventral view on the right side. And note again that not only is the brainstem home to the cranial nerves, but virtually all of the cranial nerves are exiting from the ventral or ventrolateral aspect of the brainstem. Only the trochlear nerve arises from the dorsal aspect of the brainstem in the area just posterior or below the inferior colliculi. All right, before we document the more detail about the cranial nerves, let's look at the gross anatomy of the brainstem because it's not uncommon to see cadaver views of a brainstem on test questions. First off, note that the midbrain is characterized on its dorsal surface by 2 pairs of colliculi. There's a pair of superior colliculi and a pair of inferior colliculi. So what we're going to see is virtually any section that basically is run through the midbrain must have either the superior or the inferior colliculi on its dorsal surface. And that's going to be a very good landmark because it's not uncommon for exam questions to show unlabeled brainstem sections and assume that you know where you are, whether you're in the midbrain, the pons, or the medulla. So note that the superior colliculi functionally are visually related structures. They help coordinate vertical conjugate gaze, and an area just in front of the superior colliculi that's known as the pretectal area. The tectum means roof. The pretectal area contains neurons that link the light reflex together, joining optic nerve axons with oculomotor axons. And as we'll see a little later, note the relatively close relationship of the pineal gland or pineal body, and note how it is suspended just above the point where the superior colliculi are.